Hello and welcome to my YouTube channel, AnatomyMentor. Today, I'll be discussing a topic of embryology, which is the development of the muscular system. So in this lecture, we shall be covering the essentials and the basics of the development of the muscular system, which is going to be all that you would require if you are a medical student at the undergrad level. So our learning objectives for today's discussion are that you should be able to enlist the different sources of origin of the muscular system, describe the embryological development of skeletal muscles from abaxial and primaxial precursors. You should be able to explain the embryological origin of the head and limb musculature and also the stages which are the development of the muscle at the histological level, which is known as histogenesis or myogenesis of the different types of muscle, that is skeletal, cardiac, and smooth muscle in the human body. Then at the end, we'll be talking about the clinical conditions, which are Poland sequence, prune belly syndrome, and I shall also discuss briefly the muscle diseases, which are known as muscular dystrophies. So these are our learning objectives for today. And let's start with the development of muscular system. Now, the very first point that I would like to emphasize on is over here, that the entire muscular system, remember, the entire muscular system of the body, it develops from the mesoderm. Now we know that our beginning as a human being is in the form of a trilaminar germ disc. And now these three layers are ectoderm, mesoderm, and endoderm. It is the mesodermal layer which is largely responsible for the formation of the muscular system. But there is an exception that you have to remember, that the pupillary muscles of the iris and myoepithelial cells of the mammary gland and sweat glands are ectodermal in origin. So except these, the rest of the muscular system of the human body is largely derived from the germ layer, which is the mesoderm. Now, let's start with the development of the striated skeletal muscle. Now, skeletal muscle, remember, embryologically is derived from the paraxial component of mesoderm, which is going to form somatomeres in the head region and somites from the occipital to sacral regions. Now here's a dorsal view of the developing embryo on approximately 23rd day of development. This is during intrauterine life, and you can see the area in red is showing these blocks of paraxial mesoderm, which are in the midline, and they are the paired somites. Here again is the developing embryo in the early stages, and this is now the sagittal section. You can see this is the lateral view where these somites are present in the midline in the longitudinal axis of the body of the developing embryo. And these are the segmented block-like regions. Now remember, the muscles of the axial skeleton, the body wall, and the limbs is derived from the somites. Now, which part of the somites? The myotomes. Whereas the pharyngeal arch muscles, those are the ones which are the muscles of mastication, that is the chewing movements, facial expression, the pharynx and the larynx. These are all derived from those myoblasts which originate from the unsegmented paraxial mesoderm and precordial plate. So the unsegmented paraxial mesoderm is going to form these pharyngeal arch muscles. Then the eye muscles, they are derived from the myoblasts, which originate from the mesenchyme derived from three pre-otic myotomes. Now, pre-otic means they're anterior to the area of the developing ear, that is the otic region, and they are going to form the muscles of the eye. Whereas if we look at the post-otic region, that is posterior to the developing ear region, we will see that the upper somites, there are 4 occipital myotomes, which I told you are the parts of the somites. The first pair of the 4 occipital myotomes will disappear, and the remainder, their myoblasts, will then form the muscles of the tongue. Now we're going to look at this in a very simple diagram of the developing embryo in early stages. Here we can see is the region of the pharyngeal arches. They are bars of mesodermal tissue in the neck region of the developing embryo, and they are labeled as Roman numerals 1, 2, 3, 4, and 6. And here you can see these are the pharyngeal arch muscles. And as I told you before, they're going to form the muscles of facial expression, the larynx, and the pharynx. Here you can see are the eye muscles, and here now are the somites, which are present in the midline, and the uppermost are the occipital somites, and then from there you can see are the cervical ones, and then as we go inferiorly we have thoracic somites, and over here they have been labeled as myotomes because we're talking about the portion of the somite which is going to form the muscle, and that is known as the myotome. Now looking at these diagrams, which are this is a drawing of a 6-week-old embryo. You can see the myotome regions of the somites. We can see them as the cervical ones. The uppermost are occipital, then cervical, thoracic, and lumbar, whereas the caudal ones, they will regress. And they will eventually form, if you look at diagram B over here, which is an 8-week-old embryo, they're going to form the musculature of the limbs and also the body walls, such as the abdominal muscle, external oblique, the thoracic muscles, and you can see over here the muscles in the lower limb. Over here are the pre-otic myotomes, which I told you are going to form the eye muscles. And here you can also see the pharyngeal arch myotomes, which are forming the facial muscles. Now, regarding the differentiation of a somite, I told you the somite, it has different parts. Now, each myotome part of a somite, what happens is that the myotome further differentiates into two divisions, a dorsal and a ventral division. The dorsal division is also known as epaxial division, and the ventral division is also known as the hypaxial division. Now, we can classify muscles on the basis of their innervation. And this classification will divide muscles into two groups, which are epaxial and hypaxial muscles. Epaxial muscles are the muscles which are the true back muscles. They are innervated by the dorsal primary rami. Now, the other group, which is the hypaxial muscles, are the muscles of the limb and body wall, and they're innervated by the ventral primary rami. So let's look at this classification of muscles based on their innervation. This is a cross section through the upper part of the body of the developing embryo. Here you can see is the section through the vertebra, and this here is the spinal cord, and from it emerges the dorsal root and the ventral root, which unite to form the spinal nerve. As soon as the spinal nerve forms, it immediately divides into a dorsal primary ramus and a ventral primary ramus. The dorsal primary ramus is the branch which supplies the muscles of the back. These are the epaxial muscles. Then the ventral primary ramus is the one which supplies the muscles of the body wall and also the muscles of the limbs. And these muscles are collectively known as the hypaxial muscles because they're below the axis, whereas the back muscles, epaxial, are above the body axis, right? The limb muscles are further subdivided into different compartments, that is the extensor muscles and then the flexor muscles, and they receive their nerve supply from branches accordingly. There is also another method by which we can classify the muscles of the body, and that is on the basis of their embryological origin. Now, in this classification, we use a very important landmark, which is known as the lateral somatic frontier. What is the lateral somatic frontier? Well, initially, there is a well-defined border between each somite and the parietal layer of lateral plate mesoderm. This border is known as the lateral somatic frontier. We're going to look at this in these series of diagrams from Langman's medical embryology, and they are showing us the stages of differentiation of a somite. So here in the early stage A, you can see this is the donut-shaped somite in which the cells, you can see the epithelial cells, they are closely attached to one another and they're surrounding a central lumen. And this somite is adjacent to the developing the neural tube in the midline. And here this somite now has a ventral wall and it has a dorsal wall. Now let's look at the next stage, which is in diagram B. Here you can see that the medial aspect of the somite, the cells over here, they have separated and now they're migrating towards the notochord and neural tube. This cell population is known as the sclerotome, and we know it's going to form the vertebral column and the ribs. Now, the remaining part of the somite is differentiated into two parts. This portion over here, which is the dermatome, and these two groups of cells which are colored in brown, they're showing the cells which are going to form muscle. So they can be called myoblasts. You can say that they are the myotome. This group is known as dorsomedial muscle cells, and over here we have the ventrolateral muscle cells. Now let's look over here. If this was the area of the somite, and we can see, you know that somite is derived from paraxial mesoderm. Adjacent to it is the intermediate and then the lateral plate mesoderm. Lateral plate mesoderm divides into two layers, a parietal layer which is next to the ectoderm, and over here a visceral layer which is next to the endoderm. Now the parietal layer of the lateral plate mesoderm and this over here region of the developing somite, they are separated by this here important frontier, or we could say this important boundary, which over here has been represented in the form of an imaginary green line, which is known as lateral somatic frontier. This is the part which is going to be crossed over by a few of the ventrolateral muscle cells, which will enter the parietal layer of lateral plate mesoderm. Now, why is this boundary so important? Why are we talking about this lateral somatic frontier? Because this is the one which is going to divide the muscle cell precursors into two important groups. Let's revise and recall, and then we'll talk about the groups. So pairs of somites form as the primitive node regresses caudally, and the process begins when the localized mesenchyme is aggregated to form somatomeres. And from the somatomeres, you get the donut-shaped epithelialized cells, which is the somites, and then they further differentiate into, as I told you, they're differentiated into sclerotome and then the dermomyotome. Dermomyotome separates into dermatome and myotome. And those cells which undergo epithelial mesenchymal transformation, they disperse. So mitomeres, which are in the head region, remain unsegmented. But the lateral somatic frontier, which I just showed you as that green line, separates two mesodermal domains in the embryo. The first is the prime axial domain. Now, prime axial domain, or the prime axial group of muscle precursor cells, includes those muscle precursor cells which are present in the region around the neural tube. And so this contains only somite-derived cells, or we could say the paraxial mesoderm-derived cells. The abaxial domain is the one that consists of the parietal layer of lateral plate mesoderm, together with a few of those somite cells that have migrated across the lateral somatic frontier, those from the VLL group, which I just showed you. So here we've got now these two main groups of muscle precursor cells, the prime axial group and the abaxial group. Here is a table which gives us a summary of the different muscles of the body which are derived from the respective groups. Now, in the cervical region, the scaleni, the genioid, and prevertebral muscles are derived from the prime axial group, whereas infraoid is included in the abaxial group. In the thoracoabdominal region, it is the intercostals which represent the prime axial group, whereas abaxial group are giving rise to all the other muscles, that is the pectoralis, major, minor, external oblique, internal oblique, transversus abdominis. These are the abdominal wall muscles, rectus abdominis as well, and pelvic diaphragm and sternalis. If we look at the muscles of upper limb, the upper muscles, that is rhomboids, levator scapulae, and latissimus dorsi, are derived from the prime axial group, but the distal limb muscles are derived from the abaxial group. When we come to lower limb, almost all of the lower limb muscles, they are derived from abaxial group, right? So now that we have discussed the origin of the muscles and how we can classify them on the basis of embryological origin, now we are going to discuss the histogenesis of skeletal muscle. How is skeletal muscle formed at the histological level, also known as myogenesis? So in this process, first myoblasts. Now, you know the word blast represents a precursor form. So those cells which are going to form the mature muscle cells, they are known as myoblasts. Myoblasts will fuse to form myotubes. Now, myotubes will then mature into long multinucleated muscle fibers. Then the myofibrils will soon appear, giving rise to cross striations by the end of the third month of development. And tendons are derived from sclerotome cells. So here we can see we have the quiescent cells. When they're activated, they are going to now differentiate, and once they're committed to differentiation, they are known as the myoblasts. Myoblasts are going to fuse, and because they fuse, that is why the myotubes now, they are multinucleated and they mature into the myofiber. So a single muscle cell, skeletal muscle cell, is multinucleated. The cross striations are due to the presence of myofibrils within the myotubes. So this is the hematoxylin eosine stained section of skeletal muscle, which we are looking at the high power, to the high power of the microscope. So in this histomicrograph, we can see that this here is a skeletal muscle fiber, which represents individual muscle cell, and it has many nuclei which are present at the periphery, and they're flattened oval shaped nuclei. And we can see the prominent cross striations within the cytoplasm due to the presence of the myofibrils. So remember, the patterning of the muscles is controlled by the connective tissue into which the myoblasts migrate. Here we have a table which is a very crisp summary showing us the origin and of these different muscles from the different somatomeres in the head region. We know that somatomeres, they are the loosely, you could say, dispersed mesenchymal cells, which are then going to form the different muscles in the head and neck region. And this is the sequence of the somatomeres and the muscles which are derived from the somatomeres and the individual innervation of these muscles. As I told you, the somites, not somatomeres, will form the tongue muscles which are innervated by hypoglossal nerve. Now we're going to talk about the development of the cardiac muscle. Cardiac muscle develops from splanchnic mesoderm, which is surrounding the endothelial heart tube. If you recall from the folding of the embryo lectures, we discussed this here is a cross section through the trilaminar germ disc, and we can see over here that these are the lateral body wall folds. And as these folds are going to approach the midline, these precursor cells of the heart, which are the myocardial cells, along with the endocardial tube, you can see they're going to fuse, forming a single heart tube in the midline, and it is surrounded by the myocardium. So you can see that it is also surrounded by a layer of mesodermal tissue, and this mesodermal tissue is the splanchnic layer of the lateral plate mesoderm. This is the area where the cardiac muscle cells are going to be formed. Regarding the histogenesis of cardiac muscle, remember in this case myoblasts, they do not fuse, but they adhere to one another. By adherence, we mean that there is a special attachment between the myoblasts, which is represented as intercalated discs. Myofibrils will also develop in the cardiac muscle, but they are less prominent. There are also a few special bundles of muscle cells with irregularly distributed myofibrils, and these special bundles will form the Purkinje system of the heart. So here is now the photomicrograph of the cardiac muscle stained with hematoxylin eosine at high power. And you can see over here that these are the cardiac muscle cells, and between the cardiac muscle cells, this prominent ridge or line is representing the intercalated disc. There's another one over here, and each cardiac muscle is having one or two nuclei which are prominent, round, and in the middle. The cross striations are also visible over here, although they're less prominent if we compare them to the skeletal muscle. Now we're going to talk about the development of the smooth muscle. Smooth muscle has a diverse origin. In the dorsal aorta and large arteries, smooth muscle is derived from lateral plate mesoderm and neural crest cells. Whereas in the wall of the gut and gut derivatives, it is derived from the splanchnic layer of lateral plate mesoderm. In case of the coronary arteries and blood vessels of face and forebrain, the smooth muscle is derived from neural crest cells. Only the sphincter and dilator pupillae muscles and smooth muscle of mammary gland and sweat glands are derived from ectoderm. So this is the exception which I mentioned at the very start of this lecture. Now coming to the histogenesis of smooth muscle, in this case myoblasts, they differentiate from mesenchymal cells. They do not fuse, they remain mononucleated. There is development of elongated nuclei in the spindle-shaped myoblasts. Filamentous but non-sarcomeric contractile elements develop in the cytoplasm of the smooth muscle cells, so they will not have striations. So this is an important point. that the contractile elements within smooth muscle cells are not organized into sarcomeres, and therefore striations will not be visible when we look at the smooth muscle through the microscope. Here's the hematoxylin eosine stain section at high power. You can see the spindle-shaped cell. Spindle shape means the cell is broader in the middle and tapering at the ends. And there is a single nucleus which is oval, large and prominent in the middle of the spindle-shaped smooth muscle cell. And each smooth muscle is closely opposed to the other one, so it forms a syncytium or a network. But we can see that the striations are not visible in the smooth muscle. Now that we have discussed the basic embryology and the formation of the muscles, now I'm going to discuss some anomalies of muscles that can occur. We're going to talk about, first, we're going to talk about pollen sequence. You should know about this one. It is also known as pollen syndrome. This is a rare congenital anomaly, and it typically affects boys. What happens is that on the affected side, the pectoralis major and minor muscles might be partially or completely absent. And on the same side, the nipple is also displaced. You can see over here. So this condition is known as the pollen sequence. Prune belly syndrome is another congenital anomaly of the muscles in which the abdominal wall muscles are absent. So the abdomen is distended because of atrophy of abdominal wall musculature, giving the appearance of dried plums, also known as prunes. Therefore, it is known as prune belly syndrome. Now let's discuss the muscular dystrophies. You should be aware of this, and this is a very important clinical condition which is related to the maldevelopment of the muscles. It is a group of rare inherited muscle diseases which cause progressive muscular wasting and weakness. They are known as the muscular dystrophies. The more important one, and the one which is more commonly asked even in clinical cases and your examinations, that is the Duchenne's muscular dystrophy. Duchenne's muscular dystrophy, abbreviated as DMD, is the most common one, which is inherited as an X-linked recessive disorder. So males will be mainly affected and females are carriers. There is mutation in a gene for the protein, which is dystrophin. Dystrophin is the cytoplasmic protein involved in linking cytoskeleton to extracellular matrix. So this protein is very important in the normal functioning, that is the contraction and relaxation of the muscle. And if the gene for dystrophin is mutated, that will cause a weakness of the muscle function and wasting of the muscles. This condition has an early onset when the boy is less than 5 years of age. The signs and symptoms appear and they worsen quickly. The lower limbs and the pelvis muscles are going to be involved first. And this condition, the patient suffering will have a short life expectancy, less than 30 years. Now, what are the signs and symptoms? The first important sign of Duchenne's muscular dystrophy is Gowers sign, which is positive. Now, in Gowers sign, what happens is that the patient needs to use their hands and their arms in getting up to a standing position from the floor. So you can say that they literally walk up their body. They need to use their hands and arms to walk up their body. So I'm going to show you a video for a practical demonstration of this condition, the Gower sign. So this is a boy who is suffering from Duchenne's muscular dystrophy, and the Gower sign is positive. You can see while getting up from the floor, he needs to use his hands and arms to support himself to the standing position. So he is, you can say, walking up his body. This is because of the weakness of the lower limb muscles. There are also some other signs and symptoms of Duchenne's muscular dystrophy, such as pseudohypertrophy. By pseudohypertrophy, we mean that the muscles, especially the calf muscles, might appear to be enlarged, but this is not an actual hypertrophy of the muscles. It is because of the collection of fat, that is adipose tissue. So it is known as pseudohypertrophy. There might be muscle contractures and also other skeletal deformities like lumbar lordosis, which means an excessive bending of the spine in the forward direction, and scoliosis, which is an extensive lateral bending of the spine or pelvic tilt, etc. Other than musculoskeletal conditions, the other systems of the body can also be affected in Duchenne's muscular dystrophy. Like there might be heart condition, which is the dilated cardiomyopathy. There might be neurobehavioral disorders. Okay, so here you can see that this here is showing us a few of the signs and symptoms of Duchenne's muscular dystrophy. Now, what happens is that typically a boy who is suffering from this inherited disorder, at 2 years of age, the symptoms are minimal. But as the boy grows older, when he's about 8 years of age, you can see the lordosis, which is the forward bending of the spine. And then there's a progressive wasting and weakness of the lower limb, hip, and pelvic muscles. So by the time he's about 15 years of age, you can see he's severely crippled. He cannot walk. He's on a wheelchair. There are muscle contractures. And sometimes the calves might be large and prominent, but this is pseudo hypertrophy because it is not because of the hypertrophy of the muscles. This prominence of the calves is due to the collection of adipose tissue or fat. And also you can see that the lordosis will typically disappear when the child sits. So such children, they have a lower life expectancy of less than 30 years of age. There is another condition which is known as Becker's muscular dystrophy. It also comes under the umbrella term of muscular dystrophies. It is a less severe form of Duchenne's muscular dystrophy. It is less progressive. There is a generalized muscle weakness affecting the pelvic and thigh muscles first, but generally speaking, the voluntary muscles will function better as compared to Duchenne's muscular dystrophy. Now, what is the cause of Becker's muscular dystrophy? In this case, there's also the mutation for the protein dystrophin. But whereas when we talked about Duchenne muscular dystrophy, there is virtually no functional dystrophin that is being made. But in people with Becker's muscular dystrophy, dystrophin is partially functional. So they make a shortened form of this protein, which protects the muscles of those with Becker's muscular dystrophy from degenerating as completely or as quickly as those of people with DMD. So the life expectancy is better in this case, like mid to late adulthood. This is also typically more common in males because it is X-linked recessive and females are the carriers. So it will be transmitted from the mother to the son, and the mother typically will not show any signs or symptoms of the dystrophy. Now that we've covered our topic of muscular development, we're going to just discuss a few very simple MCQs, and I'm sure this would be peanuts for you. In a newborn infant, the pupil was found to lack its musculature. Which of the following contribute to formation of pupillary muscles? Now, if you remember, I told you that generally speaking, muscles of the body, they are derived from mesoderm, but the exception is the pupillary muscles of the iris. They are derived from the ectoderm. So A is the answer for this MCQ. Now, an infant is born with poorly controlled muscles of the back, which muscle forming structure gives rise to the extensors of the vertebral column. Now, while we were talking about formation of muscles, we discussed that the muscles of the back, they belong to the category which is the epaxial muscles. So the epaxial division of myotome will give rise to muscles of the back. So A is the answer, the correct answer for this MCQ. So this concludes with today's discussion of development of the muscle system. So this was a very concise summary in which I have talked about all the essentials of muscle development. And this is what you would be expected to know if you are a medical student on the undergrad level. So we have talked about the two basic methods of classifying muscles based on their development. In one group, we talked about epaxial and hypaxial types of muscles, and that was based on innervation. Then the other method of classifying muscles was based on their embryological origin. And we use the lateral somatic frontier for classifying muscles into two groups, which are primaxial and abaxial. That was the second method of classifying the muscles. And we also talked about the histogenesis and of skeletal muscle, cardiac muscle, and smooth muscle. And then we have also discussed the congenital anomalies. So I would like you to read this topic also from your textbooks, from Langman's Medical Embryology, and also from, which I recommend, is The Developing Human Clinically Oriented Embryology by Keith Elmore. And if you like today's discussion, don't forget to like and subscribe to my YouTube channel, Anatomy Mentor, and also hit the bell icon for notifications and updates related to any further uploads that I will be making. And if there is any topic that you need help with, you can mention in the comment section below the video. Thank you. Take care. Best of luck for your exams.